Hello, I'm Dr. Melissa Morala Caranto, and I would like to thank the organizing committee for the opportunity to speak to you on adult patients with pulmonary hypertension for non-cardiac surgery. I have no disclosures. For this case, I would like to acknowledge my boss, Dr. Teresa C. Menor. This is a case of LB, a 60-year-old male diagnosed case with renal carcinoma right, hypertensive atherosclerotic cardiovascular disease in sinus rhythm, functional class 2, valvular heart disease, severe pulmonary hypertension, heart failure with preserved ejection fraction, NYHA class 1, type 2 diabetes mellitus, non-insulin requiring, obstructive uropathy secondary to renal mass, and hypothyroidism in euthyroid state. Scheduled for cystoscopy, retrograde pyelogram, radical nephrectomy right. Patient is hypertensive for more than 10 years, diabetic for more than 10 years, and hypothyroid for more than 5 years. He was previously admitted for these indications. He is a chronic smoker, alcoholic beverage drinker, and he is fully vaccinated for COVID-19. On physical examination, patient was conscious, coherent, and not in cardiorespiratory distress with stable vital signs, hypertensive at 150/70, O2 saturation of 99% at room air. Cardiovascular examination revealed an adynamic precordium with a non-displaced point of maximal impulse, normal heart sounds, normal rate regular rhythm with a grade 3 holosystolic murmur with no thrill or heave. Chest and lungs, abdominal, and extremity neurological examinations were all normal. Recent workup, including coagulation profile, arterial blood gases were also normal. 2D echo revealed a normal ejection fraction, dilated left atrium, right atrium, and right ventricle, moderate MS with moderate to severe MR. Aortic stenosis was read as moderate but may be underestimated due to the severity of MR, with moderate aortic regurgitation. Pulmonary hypertension with systolic pulmonary artery pressure of 113 millimeter by TR-JET method. Patient is on sildenafil, furosemide, and medications for hypertension, diabetes, hyperlipidemia, and hypothyroidism. What is pulmonary hypertension? I will be discussing the hemodynamic definition, diagnosis, pathogenesis, and treatment. Pulmonary hypertension is defined as a right heart catheterization by a mean pulmonary artery pressure of greater than 25 millimeter mercury. In the 2018 Pulmonary Hypertension World Symposium, a reduction in the upper limit of the mean pulmonary artery pressure to 20 millimeter mercury was proposed because the 25 millimeter mercury represents more than 2 standard deviations above normal. Patients with pulmonary hypertension can be classified into 5 groups according to hemodynamic, etiologic, and pathologic characteristics. Pulmonary vasodilator therapy is predominantly indicated for patients with Group 1 pulmonary arterial hypertension and Group 4 chronic thromboembolic pulmonary hypertension, although the primary treatment of CTEPH is pulmonary thrombo and arterectomy. Management of Group 2 and 3 patients were focused on the underlying heart and lung conditions. Our patient belongs to Group 2. Statistics obtained from a local study in 2011 and an international study dated recently did not differ much as to the etiology of pulmonary hypertension presenting for interventional treatment. These local studies by Perete et al. And Faustino Balares et al. Demonstrated the correlation between high probability VQ scanning, hilum width in chest radiography, and pulmonary hypertension. This is the chest X-ray of our patient, showing a wide hilum consistent with severe pulmonary hypertension with outward bulging of the right and left atrium and the downward sloping of the right ventricle consistent with mitral valve pathology. In this study by Tenorio et al. In 1990, reviewing 70 pathologic hearts with pulmonary hypertension from the Philippine Heart Center autopsy collection, With the establishment of the hospital in 1976, they have shown that regardless of etiology, there's a similar finding of medial hypertrophy. Pilkington et al. In 2015 demonstrated that various interrelated processes result in the same endothelial dysfunction, favoring vasoconstriction, vascular remodeling, and excessive cell proliferation in the presence of reduced cell apoptosis and thrombosis. You have a decrease in prostacyclin, PGI-1, and nitric oxide, and an increase in thromboxane A2, phosphodiesterase 5, and endothelin 1. These factors stimulate smooth muscle cell proliferation, hence medial hypertrophy that is seen in autopsy. Thus, the treatment revolves around the use of synthetic prostacyclin analogs, of which iloprost is available via inhalational route. Phosphodiesterase 5 inhibitor, most common of which is sildenafil, trade name Viagra, and endothelin receptor antagonist bosentan. As mentioned earlier, the surgical treatment of group 4 chronic thromboembolic pulmonary hypertension is pulmonary endarterectomy. So what is the implication of pulmonary hypertension in patients with non-cardiac surgery? We will look at anesthesia concerns, perioperative outcomes, risk assessment, perioperative strategies, implications of COVID-19, multidisciplinary approach, and the debate of GA versus RA. We need to avoid increases in pulmonary vascular resistance. Stepan et al. In 2018 and more recently enumerated these factors that increase PVR. Hypoxemia and hypercapnia brought about by sedation, analgesia, and inadequate mass ventilation, delayed intubation, acidosis from hypovolemia, infection, decreased cardiac output, and hypoventilation. Hypothermia from cold intravenous fluids or ambient temperature, atelectasis, and hyperinflation. So we need to optimize tidal volume and peak and expiratory pressure. Catecholamine increase brought about by pain, inadequate anesthesia, and anxiety, and control the use of pure alpha agonist. Homeometric autoregulation describes the maintenance of RV systolic function in response to an elevated PVR, an intrinsic adaptation response that enables the RV to maintain stroke volume without having to depend on the Frank-Starling mechanism. However, intraoperative interventions that either compromise RV homeometric autoregulation like sympathetic block, such as the subarachnoid block, thoracic epidural block, vasovagal stimuli, or anesthetic drugs with a negative inotropic effect, or disproportionately decrease the compliance in small pulmonary vessels like microembolism, positive pressure ventilation, pulmonary artery clamping, cytokine storm after tourniquet release, can precipitate RV failure and sudden death. Load-dependent changes in RV function can also impact negatively on cardiac output. An excessive increase in RV preload from fluid administration, fluid redistribution, or blood transfusion can increase wall stress and endocardial ischemia, leading to a severe tricuspid regurgitation and systolic RV dysfunction. A disproportionate decrease in preload to a hypertrophied and fibrotic RV with diastolic dysfunction from vagal overreactivity, bleeding, overdiuresis, vasodilatation, impaired venous return owing to increased intra-abdominal pressure and vena cava compression can cause decompensation and low cardiac output state. Cardiac output should therefore be optimized perioperatively by controlling RV preload and afterload, supporting RV function, and ensure adequate myocardial perfusion with inotropic support and avoiding or anticipating perioperative insults. In a U.S. coding study of 140,000 patients with pulmonary hypertension, major cardiac events and death occurred in 4 to 8% of those compared with 1 to 2% of those without pulmonary hypertension. Perioperative mortality is 8.3% with myocardial infarction in 4.3% and stroke in 1.9%. Perioperative mortality in elective surgery ranged from 3 to 8% with death mostly relating to RV failure occurring in 48 hours after surgery. Perioperative risk is influenced by patient factors, including the severity of pulmonary hypertension, RV dysfunction, exercise performance, and functional status. Surgical factors, including the urgency, length and type of surgery. Mortality after emergency surgery is significantly higher at 15 to 50%. For orthopedic surgery, lower limb joint surgery poses an increased risk of intraprocedural pulmonary embolization of bone marrow, bone debris, and cement causing an increase in PVR and acute RV failure. Laparoscopic surgery, increasing abdominal pressure from CO2 insufflation can reduce venous return and cardiac output. This is compounded by the effects of an upward diaphragmatic displacement or a head-down Trendelenburg position on lung compliance and functional residual capacity. Rapid insufflation of CO2 can also cause a vagal bradycardia, which in patients with pulmonary hypertension can lead to RV distension, impeded right coronary flow, and cardiac arrest. International pulmonary hypertension guidelines strongly recommend that a validated risk assessment score in pulmonary hypertensive patients should influence the type and intensity of treatment. The aim is to achieve a low-risk profile for all patients, hence improving survival. This is a simple traffic light risk assessment tool looking at clinical profile, symptomatology, and functional class. RV function assessment, whether it is preserved, impaired, or reduced, using imaging tools like 2D echo, magnetic resonance imaging, and right heart catheterization. Exercise capacity using the 6-minute walk distance and cardiopulmonary exercise testing, biomarkers using the B-type natriuretic peptide and the N-terminal pro-B-type natriuretic peptide. Anesthesia perioperative strategies include pulmonary vasodilator therapies per OREM or per NGT, pulmonary endarterectomy surgical, or balloon pulmonary angioplasty interventional in CTEPH prior to time-sensitive surgery like cancer resection, perioperative anticoagulation, optimization of diuretics and comorbid conditions, prehabilitation, and post-rehabilitation. In patients with COVID-19, micro and macro pulmonary thrombosis with RV dysfunction are common echocardiographic findings. Residual impairment in lung perfusion alongside resolving parenchymal inflammation has been observed in recovering patients. Careful preoperative assessment and perioperative monitoring with echocardiography is strongly recommended in this patient group. This is a composition of the multidisciplinary team: surgeon and anesthesiologist, pulmonologist, cardiologists with pulmonary hypertension expertise, critical care physicians, transplant physicians, and chest radiographers. We need to consider these factors in planning. Do we need to operate? Risk versus benefits versus the expected survival related to pulmonary hypertension. What information do we need to make this decision? Are there non-surgical alternatives? Have we optimized pulmonary hypertension preoperatively? Do we need an updated workup like right heart catheterization, BNP, 6-minute walk test, echo, CPET, risk assessment, and consent? We need to inform the family of a possible mortality. Is the patient suitable for ECMO, transplant if needed, where to operate, general versus the cardiac theater? Anesthetic factors, general anesthesia versus regional anesthesia. Do we need to modify the technique? Surgical approach, laparoscopy versus open surgery, perioperative monitoring using advanced cardiac output monitoring, pulmonary arterial hypertension therapies around general anesthesia, surgery or while fasted, anticoagulation around surgery, especially for chronic thromboembolic pulmonary hypertension, arrhythmias, and stroke. Now for the debate. These articles came out this year in the Journal of Cardiothoracic and Vascular Anesthesia. In the blue corner, the pro-GA stand is that general anesthesia is superior to regional anesthesia for patients with pulmonary hypertension undergoing cardiac surgery. In the red corner, the pro-RA stand is that general anesthesia is not superior to regional anesthesia in patients with pulmonary hypertension undergoing non-cardiac surgery. Round 1. Issues in airway and respiration. The pro-GA points out the secured airway, the application of peak and expiratory pressure not only with GA is only possible with GA, and this has been shown to reduce atelectasis, reduce pulmonary shunt fraction, and manage hypoxemia. Improved matching of ventilation and perfusion also reduces hypoxic pulmonary vasoconstriction, thereby directly lowering PVR. Also, through this endotracheal tube, we can administer 100% oxygen and inhaled pulmonary vasodilating agents. Moreover, you will see this elaborate series of unfortunate events leading to an increase in PVR in patients who are either oversedated or undersedated, hence emergent conversion to general anesthesia eventually. The pro-RA comes back with controlled ventilation often is used during GA in an attempt to mitigate the aforementioned hypoventilation and oxygenation sequelae. Yet, positive pressure ventilation induces number of adverse events in the setting of pulmonary hypertension. Although relatively low to moderate tidal volume (RR) and PEEP strategy has been recommended for patients with pulmonary hypertension, the possibility of alveolar overinflation persists because peak airway pressures are inherently elevated over the spontaneous ventilation. The native airway providing less sedation and general anesthesia to the patient will produce a decreased risk of hypoventilation. Also, inhaled pulmonary vasodilating agents can be administered via non-invasive ventilation. Round 2, preload, pro-GA. Sympathectomy in regional anesthesia induces vasodilation. Pro-RA, epidural incremental dosing or peripheral nerve blocks reduce vasodilation. Round 3, heart rate. Pro-GA, good level of anesthesia controls heart rate. Pro-RA, sympathectomy controls heart rate. Round 4, contractility. Pro-GA, good cardiac support. Pro-RA, less cardiodepressant effects. Now, what is my anesthesia management for this patient? I will discuss the preoperative preparation, conduct of anesthesia, postoperative management. We did a Zoom family meeting to discuss perioperative risk, including the need for advanced cardiac support, including ECMO, ceilings of care, and obtained informed consent. It is not uncommon for patients with valvular heart disease with pulmonary hypertension to be treated with antiplatelet and anticoagulant medications as antithrombus prophylaxis. These were according to the STS 2021 guidelines. In the management of patients with antiplatelet, anticoagulant medications, aspirin is not discontinued and clopidogrel is discontinued for 5 days prior to elective surgery and abridged with low molecular weight heparin or heparin. We thank our cardiology counterparts for giving us a patient with normal rate, regular rhythm, and being prepared for elective surgery. Hence, no antiplatelet or anticoagulation medications were given perioperatively. Upon receiving the patient in the operating theater, we hooked the patient to standard ASA monitors and obtained the following vital signs. After giving midazolam, we placed our invasive monitors. Arterial line was placed on the left radial for beat-to-beat coronary perfusion pressure monitoring targeting systemic diastolic pressure and provide an avenue for ABG sampling. Pulmonary artery catheter was placed on the left via the introducer sheath on the left internal jugular vein with the baseline PA pressure of 85 over 10 millimeter mercury. PA pressure monitoring provides an avenue for RV preload assessment in patients with PA hypertension with preserved ejection fraction. We place an epidural catheter at L4 to L5 interspace for continuous lumbar epidural anesthesia. General endotracheal anesthesia was started with pre-oxygenation at 5 liters per minute using adult face mask. Induction of general anesthesia was begun with fentanyl at 2 microgram per kilogram, propofol of 1 milligram per kilogram, and rocuronium of 0.6 milligram per kilogram. Sevoflurane was turned on at 3 volumes per cent with the fresh gas flow at 2 liters per minute, 100% oxygen. 5 minutes after giving the relaxant, intubation was done using a videolaryngoscope Mach 4 with an endotracheal tube size A, 21 centimeters at the level of the incisor. Patient was hooked to mechanical ventilator with the following setting: volume control, tidal volume of 6 ml per kilo, RR of 12, IE ratio of 1:2, PEEP of 5 to 10 centimeters water. Arterial blood gas, hemoglobin, hematocrit, capillary blood glucose, and electrolytes were tested before and after the surgery. Patient was started on milrinone. These are other cardiac supports which may be given as necessary. In this patient, we did not need to use these cardiac supports. Surgery lasted 1 hour and 55 minutes with 300 cc estimated blood loss. Table extubation was done after achieving good spontaneous ventilation and complete reversal with Sugamadex. For pain control, paracetamol 1 gram IV and morphine 2 milligram via epidural catheter was given. And the epidural catheter was removed on the second post-op day. We did DVT prophylaxis. Post-operative course was unremarkable with a good control of pulmonary artery pressure except for bibasal rales on day 2 with chest x-ray showing bilateral pneumonia with of the both lower lung fields, which resolved with an incentive spirometry. The patient was discharged on day 8. So for RA versus GA, we use both for this patient. These are my references. The Philippine Society of Cardiothoracic Anesthesiologists would like to thank you all for attending the PhilSCA pre-convention meeting, Optimizing Blood Management in Cardiovascular Disease and Cardiovascular Surgery, Too Much or Too Little, last December 2. Free registration, care of the Philippine Society of Anesthesiologists Zoom platform. Thank you, PSA. And we would also like to invite you to the PhilSCA Heart Month activity in collaboration with the Philippine Heart Center Cardiovascular Anesthesia Division with the theme, Anesthesia Point of Care Hitting the Target Every Time. This is a hybrid conference on February 1 with online lecture and on-site workshop.